And I'll go ahead and start the speaker as well. Dr. Triplett is an associate professor in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington, who primarily does clinical service at Fred Hutch. And is very interested in immunocompromised populations and particularly in lung cancer screening, and has been working with us in the Madison Clinic on a project to enhance lung cancer screening efforts in our patient population. So he'll be going first. And then we have Manoj Menon, who also is an associate professor, but he's in the Division of Hematology Oncology. He's also the program director of their fellowship. And he also works at the Hutch, but he's also at Harborview and has a clinic at Madison Clinic to see our patients who have malignancies in our clinic. And he's going to be talking about HIV and malignancies as well. So let's let them get started. Thank you.
Thanks, Shirisha. I appreciate the opportunity to talk to you all today. As Shirisha said, I am a pulmonologist, and I'm one of the few pulmonologists over here at the Hutch. So I practice primarily with patients with cancer diagnoses or at-risk findings for cancer. I'm the clinical director of our lung cancer screening program and our lung cancer early detection program. And then my research is really kind of blending methods from epidemiology to implementation science to try to make sure that there's equity as we implement lung cancer screening as kind of the newest kid on the block in terms of screening modalities. So I'm going to talk today a little bit about the increased risk of lung cancer in people with HIV with a heavy focus on prevention. So I'll leave this up for a second. So this is the disclaimer for the whole session. And then in terms of my own disclosures, I'm presenting some research that hasn't been published that's funded by the NCI. And the funders didn't have any role in the conduct of the research. So really my objectives and what I hope you get out of this talk is that at the end of this, you'll be able to define the risk of lung cancer and the risk factors for lung cancer in people with HIV, that you'll be able to describe some approaches to both primary and secondary prevention of lung cancer, and then understand approaches to try to tailor those prevention efforts, including smoking cessation and screening for a population of patients that you take care of with HIV. So in terms of the epidemiology of lung cancer, so this is lung cancer at large in the United States. So this is in the total population. And what you can see are the common types of cancer on the left, the new cases of cancer in 2022, and then the estimated deaths from these cancers. So lung cancer represents about 12% of all new cancer diagnoses, but what you can see in the right-hand column on the estimated deaths is that the deaths from lung cancer dwarf other causes of lung cancer. So lung cancer is by far the leading cause of death in the United States, and that's really been unchanged for a number of years. In terms of the impact of lung cancer in people with HIV, we've seen a major shift that has a lot to do with, what people call the graying of the population or the aging of the population in people with HIV. So of the 1.2 million people in the United States with HIV, more than 50% are now over the age of 50. So that's a huge epidemiologic shift over the last 20 years. That's a great thing in terms of public health efforts and medical therapy, but it's led to a lot of emphasis on conditions related to aging in people with HIV. So lung cancer is the most common cause of a non-AIDS defining cancer, which are now higher in incidence than AIDS defining cancers. It's the leading cause of cancer death. And in certain populations, when you look at it, it's actually the leading cause of death. And the cumulative incidence has increased with improved HIV management, as I've said. And that's a little bit different than the general population, where we've seen a decline in lung cancer that's kind of followed and lagged behind declines in the smoking prevalence in the population. So if we look broadly at the incidence of lung cancer in people with HIV and we put it into the context of other cancers, this is an analysis of the HIV cancer match study from the NCI. So this was 9 states and territories that had the ability to match HIV data, had a specific HIV population with SEER registry cancer data. And this is data from 1996 to 2012. And so it represents 448,000 people with HIV, and then calculates the standardized incidence rate, which you see on the right side, which is standardized to the US population by sex, age, race, ethnicity, calendar year, and then the registry area. So trying to have some comparison between people with HIV and the general population. So in terms of all cancers, the incidence is higher in people with HIV, so about 1.7-fold. In terms of AIDS-defining cancers, as you would expect, much higher in people with HIV, as there are certain AIDS-defining cancers like Kaposi sarcoma that you're not going to see very often in people without HIV. So that's a 14-fold incidence. But we do see a higher risk too in these cancers that are associated with aging in the general population. So about 1.2-fold for the non-AIDS defining cancers. And a large bucket of those are virus-mediated cancers, and those are much higher in people with HIV. So of these non-virus-mediated cancers, of which lung cancer is the leading cause, we see a relatively similar incidence in people with HIV and without. But in lung cancer specifically, we see this almost 2-fold increase in people with HIV compared to the general population. And if we look at that a different way, one of the things I was kind of talking about earlier was this kind of shift that's come along with the aging population. This looks, this is a nice analysis that looked at national level data and looked at the incidence in different calendar eras here, 1996 to 99, and then 2000 to 2004, and then 2005 to 2009. And what you can see on the right in the uninfected population is that actually the incidence has dropped. So the cumulative incidence is now 2.3% by the age of 75. And what we've seen in people with HIV is that the cumulative incidence of lung cancer is actually going up. So over the whole era, there's an increased risk, 3.4% versus 2.8% of the cumulative incidence, but that is going up over time versus down. So the increased risk is largely driven by smoking behavior. And that's a complex issue that has a lot to do with social determinants of health in people with HIV in the United States. So the prevalence of smoking currently is about 35 to 50% across Western countries, and in the United States is about 40%. And that's about double the rate of uninfected adults. There have been some successes in smoking cessation at a population level in people with HIV. About 60% of people with HIV used to be smokers, so clearly there's some substantial efforts to address smoking behavior in folks with HIV. Another important thing that still needs to really be unpacked is that HIV is an independent risk factor for lung cancer. Obviously, it's an independent risk factor for a lot of diseases with aging. There may be some tie to premature senescence, with the maintained HIV reservoir. I don't think people have really unpacked that yet, but most common markers, CD4, CD8 ratio, things like that, viral load, nadir, haven't really been tied to lung cancer. So it's going to take a little bit more effort to unpack what drives that risk. So some of the analysis that have shown this kind of increased risk of lung cancer in people with HIV, it's actually really hard to untangle because of the smoking behavior. But this was a nice study that had data from the large VA cohort VAX, and analyses were adjusted for age, sex, race and ethnicity, smoking behavior, COPD, bacterial pneumonia. It's a little bit limited in that there wasn't a complete adjustment for smoking in terms of duration, but there are several kind of sensitivity analyses that kind of reassure you that yes, HIV infection seems to be, as kind of highlighted in the top, independently associated with lung cancer, as are other things you might think that are important, including COPD and previous bacterial pneumonia. When you looked at, again, the traditional risk factors regarding HIV control, like CD4 count, CD4 nadir, viral load, things like that are not clearly associated. So in terms of primary prevention, this is your biggest bang for the buck, right? We'll talk about lung cancer screening, which has the ability to reduce lung cancer death, but obviously smoking is highly tied to cardiovascular death and all-cause mortality. And this is a really nice study using national level data out of Denmark, and it's a nationwide cohort of people with HIV with matched uninfected controls, looking at kind of life expectancy by smoking status in a large population. So if you take a 35-year-old with HIV who's a current smoker, their life expectancy at the present time is 63 years, just about. But then if we look at people with HIV and a comparator uninfected group that's never smokers that are matched, roughly similar life expectancy. So that's what we see overall. That life expectancy in people with HIV is at or is approaching that of uninfected populations, but really that smoking may have more attributable mortality in HIV than it does in other populations. And that may be tied to this idea of premature senescence and risk for chronic diseases in general. This is a really great study from Krishna Reddy out of Harvard, who worked with some of the most recent kind of HIV/AIDS epidemiologic data that was available to create a Monte Carlo micro simulation with kind of different factors plugged in to try to understand and predict the impact of smoke exposure on cumulative lung cancer mortality. So now we're looking kind of just at the impact of lung cancer. And it basically assumes, and I think this is very relevant to our patients that smoke, that, at the age of 40, all these folks were current smokers, and kind of what can happen to these patients if they quit smoking, and how does that affect their lung cancer risk. So everybody but that dotted red line at the bottom, the never smoker, it is assumed to be smoking at the age of 40. And what you can see is that there's a huge difference between folks that continue to smoke, kind of those upper lines, even light smoking behavior, versus folks that would quit at the age of 40. So from this analysis, people with HIV who smoke are about 6 to 13 times more likely to die from lung cancer than AIDS-related causes in this simulation. Quitting by the age of 40, as I said, can result in drastic reduction in lung cancer mortality. Just as an example of that, within the simulation, a 40-year-old heavy smoking man who continues to smoke has a 29% cumulative lung cancer mortality by the age of 80, and drops to about 8% if he quits at the age of 40. And in estimating, what smoking cessation can do on a population level, if we take some of our kind of best evidence that says if we use appropriate guideline-based smoking cessation, we can help about 20% of people quit smoking. So if 20% of current smokers quit, you're eliminating 12% of the total lung cancer deaths. So real huge benefits, even just in lung cancer, from smoking cessation. So in terms of how to approach smoking cessation in people with HIV, I think, and I'm sure Dr. Menon is going to talk a little bit about this, I think a lot of the story in cancer and HIV is a hesitance to apply standard therapies that work in other populations to people with HIV, with this concern about side effects or other things, because people with HIV are often not included in clinical trials. But in terms of the pharmacologic therapies we have for smoking cessation, which I would encourage you to use varenicline. It has the best data, and think about bupropion as a possibility in people that might have contraindications to varenicline, which are actually quite few. That both varenicline and NRT are very safe and effective in people with HIV. So there's been 2 phase 3 trials that were published about 5 years ago of varenicline in the US and in France, specifically in people with HIV. There are limited studies of interventions employed specifically in people with HIV, but what we can kind of glean from those studies that there's improved efficacy for intensive interventions, that combining some behavioral support and pharmacotherapy, and the best pharmacotherapy being varenicline and dual NRT, so giving people long-acting things like patches, and then short-acting things for craving like lozenges. And that patient motivation is likely a key component of cessation, and we'll kind of get back to that patient motivation piece when we talk about lung cancer screening. There's increased interest in vaping as a harm reduction strategy, so that comes up all the time. You'll probably see these headlines from the UK that they actually give out vape pens and things at cessation events. We're not doing that. We don't think vaping we don't think harm reduction with vaping, something that's really not well understood, is the best strategy, but there's interest in that. And then, people with HIV carry multiple identities, and the intersection of those identities is really important. So thinking about your patients as individuals with different circumstances and motivations to quit smoking. In terms of secondary prevention, lung cancer screening is really the first avenue we have for kind of secondary prevention of lung cancer. And all this data comes from a trial that was published in 2011, the National Lung Screening Trial. We now have some confirmatory data, but I think it's worth looking at this trial because it still informs a lot of the things that we say about lung cancer screening. So in terms of this study, it was a massive undertaking by the NCI. It was a randomized controlled trial of about 53,000 folks at 33 sites. These were all folks who were considered high risk for lung cancer, so were 55 to 74 at the time of the trial, had at least a 30-pack year smoking history, and they were randomized to chest X-ray versus low-dose CT for 3 rounds of screening. Ultimately, the reduction in lung cancer mortality was 20% as a relative reduction, and then the all-cause mortality reduction was 6.7%. So lung cancer is driving some, but clearly not the majority of the deaths. In terms of thinking about what concerns we need to have about lung cancer screening, I always pull up this slide that showed that in all rounds of screening, what I've highlighted is this, almost a quarter of patients had a positive finding on lung cancer screening. Now, the flip side of that is they use a very sensitive threshold for positive. If you had a 4-millimeter nodule, you were considered positive. We don't do that anymore in clinical practice. So we've kind of cut the positivity rate. If you order lung cancer screening, we're using something called lung rad. So only about half of that number, so maybe 16%, have positive findings at the current time. But still a concern. So this idea of false positives. And so when people started to conceptualize the benefits and harms of lung cancer screening in people with HIV, knowing that very few people with HIV are probably included in these large-scale clinical trials, and there wasn't clear contraindications, but we have no indication that a large number of folks would have been included. The benefits could be very high. So in people with HIV, it depends on the study you look at, but maybe a 3 to 5 year younger age in terms of median age at diagnosis of lung cancer. So you might be able to capture some of that younger group. There's this increased incidence that we talked about, which is maybe 1.5 to 3-fold, depending again on the study. And then you're going to have enrichment for eligibility. This is the population with increased tobacco use. So as they age into that 50+ category, you're going to see a higher percentage of eligible patients in a clinical population of people with HIV. Some of the concerns are that goes along with a lot of other potential comorbidities of aging, so more competing risk. There's a potential increase due to pulmonary infections, inflammation, immunosuppression, other things. The potential risk of false positives is there. And then this idea that you might be then at risk for increased diagnostic and therapeutic harms if you're finding a lot of infectious stuff, inflammatory stuff that's relatively irrelevant. So the first thing people did, and I show these studies, and I'm not sure I take a lot out of them myself, but just to show you that they do exist, is 2 very small screening trials in people with HIV, so single-arm trials. So folks that didn't really quite meet our, standard criteria for lung cancer screening, but were considered to be at high risk for lung cancer and underwent some intervention that's kind of similar to lung cancer screening done here in the United States, so that a control, and just showed, some of them have positive findings, and that maybe there was poor adherence to subsequent scans. We see that in the general population in one of the studies, and hey, we did 18 diagnostic procedures and there were no adverse events. So the kind of first thing people did was try to apply some criteria for lung cancer screening to people with HIV, but again, in a very kind of small and uncontrolled fashion. some of the studies our group did at the same time was really try to use larger cohorts without, putting people through lung cancer screening to say, hey, how concerned should we be about these things that are maybe tipping the scale against lung cancer screening? Like, should we be concerned about the false positives? So this was a study of 158 people with HIV and 133 matched folks without HIV who met criteria for lung cancer screening and had a CT as a part of a different study, so a secondary analysis of that data. And basically, we saw that there was a similar portion of non-calcified nodules in people with HIV, so about 25% versus the matched people without HIV, 22%. And that, the odds of nodules was exactly the same if you looked at people who had a CD4 count greater than or equal to 200, so people that were not immunosuppressed. And then in people with HIV, some markers of chronic inflammation, soluble CD14, and then emphysema, which has this, is very wrapped up with both smoking, but then kind of inflammatory response was also associated with higher risk of false positive findings. When we looked at screening harms, we looked at a larger cohort within the VAC study, about 44,000 people with HIV and 88,000 controls, and looked at people who had undergone procedures that are common in the setting of kind of a false positive for lung cancer screening. So what if you take kind of this matched cohort and people that have undergone bronchoscopic or transthoracic biopsies? So those are the different kind of matched colors. And what you really see is that in terms of the complications, they're low across groups and they're relatively similar in terms of chest tube hemorrhage, pneumothorax, or hospitalization after these procedures. And then, back to the modeling, we're probably not going to have a large clinical trial of people with HIV undergoing lung cancer screening. That seems pretty unfathomable with the numbers that you would need to show that mortality benefit. So in our group, we adapted the lung cancer policy model, which is a Monte Carlo microsimulation that's actually used to inform and extend the USPSTF guidelines. So to use inputs from these different clinical trials coming out of Europe, in addition to the NLST and real world data, to try to inform the USPSTF's lung cancer screening guidelines. And this included information from VAX, SEER data, Kaiser Permanente's HIV cohort, and examined a combination of different screening criteria where you might shift the age at initiation 45 to 55, the age of termination of smoking, or the age of termination of screening, the smoking pack years. Importantly, this excluded non-ART adherent people with HIV and then folks with a low CD4 count. So this is considering people that are on therapy with a maintained CD4 count. And what we end up drawing from this is kind of an efficiency threshold to figure out what are the most efficient screening strategies. And efficient screening strategies lie at the kind of curve of the percentage of mortality reduction, and then thinking of number of screening exams you have to perform as a surrogate for false positives, obviously, because the more screens you do, the more CTs you do, the more potential harms that you have. And if we look at the kind of the highlighted point, that was the initial USPSTF criteria back when it was first established in 2013. This age 55 to 77 and 30 pack years, that was actually Medicaid's modification. The relative lung cancer mortality of 19% is very similar to the 20% in the non-screen population, so very similar. What you can see is that kind of lower pack years and a more inclusive age range, including kind of the current criteria, which is 50 to 77, results in a higher lung cancer mortality reduction at the cost of more CTs, but still lies on this efficiency threshold. So right now where we're at, we have new guidelines from 2021, and that's again based on very similar analyses of the lung cancer policy model, just in people without HIV. Have extended that age range to age 50 to 80. And again, the stop time is 77 for people that are just covered by Medicare. 20 plus pack years, so that's dropped, and currently smoking or quit within the last 15 years. So a little bit more inclusive criteria for lung cancer screening than the initial. In terms of recommending, right now, we're at the point where both because of practical issues like payment and insurance coverage and other things, I think it's important that we follow USPSTF guidelines in people with HIV. But I think we also need to consider HIV control, competing risk of mortality, patient preferences, and this concept of considering all those things within lung cancer is called shared decision-making, which includes personalized benefits and harms of screening, screening in the context of overall medical care and goals, and then an emphasis on smoking cessation and abstinence, knowing that, that's the biggest bang for your buck. The current state of screening is low. So we don't know a lot about this in people with HIV, but in 2 studies, maybe somewhere between 2 and 15% of all people with HIV are being screened for lung cancer. So, right now there's a lot of work to be done, essentially, to improve screening rates in people with HIV. So as Shirisha mentioned, we've been working with the Madison Clinic to essentially create a tailored shared decision-making tool to support lung cancer screening implementation for people with HIV. The first aim is a mixed methods approach to understanding determinants, so kind of facilitators, barriers, knowledge of LCS and people with HIV, including focus groups with eligible patients, interviews with providers, and then this iterative process of working through tools and helping design tools that can be used to aid kind of a tailored shared decision-making process. And then aim 2 is a single arm pilot trial of this tool. I'm running out of time, so I'm going to go quick. So we had 64 folks with HIV, and we purposely recruited kind of a diverse sample, so tried to include more folks with race, ethnicity other than non-Hispanic whites. Tried to include women whenever possible, but there's a male predominance as is seen in the clinic at large. We had about half current folks that were currently smoking and half folks that had quit, and a diverse mix in terms of income and insurance coverage. And about a quarter had had a lung cancer screening exam before, and a large amount had reported some other types of cancer screening. So when we looked at the themes that came out of this initial group of interviews and then focus groups with patients, we saw a lot of enthusiasm for prevention. This quote, I think it's just important for people with HIV in general to have checkups regularly or screenings regularly for things that are important, like lung cancer and other forms of cancer, because we're so susceptible. Saw a lot of support for tailored care, a high awareness of the problem of lung cancer and HIV. A lot of enthusiasm for nested screening decisions within patient-provider relationships. So this quote, I got to hear it from my doctor, and if they recommend it, that I don't have it, then I don't have it. If they recommend that I do, then I will. The knowledge of HIV or lung cancer screening was low in both patients and providers compared to other screening modalities. And then the most common barriers that were mentioned by both the patients and providers were issues of cost and coverage. If we looked at the patients themselves and just kind of what they said, independent of the providers, there's this idea of a teachable moment with smoking cessation. So this idea that maybe you could leverage this in the lung cancer screening conversation. It's a lot of support for evidence and data, and some of that may have to do with doing this within Madison Clinic, where there's a lot of studies going on. But in terms of a quote regarding that, I think we are much more aware of our healthcare needs and concerns and are much more aware of how we are doing and what we need to worry about than most other people. And then this importance of survivorship. So I think this was really important, this perception of a shift in what people thought was their future reality at the time of HIV diagnosis and what they're concerned about now, which is improving their health. So this quote, I never thought I would turn 25, which is the reason that I drank and smoked and did a lot of drugs, because I was for sure going to die. So the fact that I'm still here and I've been smoke-free for 8 years, the life we have, no idea. In terms of the provider themes, it was the providers themselves who were much more likely to mention barriers to prevention. This quote, I'll let you all read since I'm running short, but basically saying, patients have a lot going on. They have to manage their diabetes, substance abuse, mental health. It's a little tough to also include lung cancer screening. And then they pointed out specific lung cancer screening barriers and the fact that lung cancer screening is going to fall below some other things, particularly primary prevention efforts. So when we were creating a tool We took a lot of this feedback, and again, we worked iteratively with patients and providers looking at different tools, and we wanted to create something facile, easy to use, embedded in the EHR, can take advantage of the data that these patients have readily available. We can look at lung cancer risk specifically for people with HIV. We can make the level of detail customizable to a patient, because a lot of folks wanted a lot of detail and a lot of folks wanted very little. There's a real emphasis on using figures and emphasizing survival. So this is what it ended up looking like. This is the broad overview for people that don't want a lot of data, where we just tell them, hey, your screening benefits outweigh the harms. You're eligible, your risk is higher than average, and you're at low risk for harm, so we encourage screening, and then we tell you the harms. If you want more data, this is the data that's pulled from the EHR that includes the NCI's tool for calculating lung cancer risk with a modifier for people with HIV, the VAX index to look at risk of mortality, and then a number needed to screen. Clearly, how many similar patients would you need to screen to avoid one death? And then it tells people why they fell on this threshold of discourage screening to encourage screening. And then we have these nice pictograms for people that want to see survival data in an absolute term, and then harm data in an absolute term. So in conclusion, people with HIV are about 1.5 to 3-fold higher risk of lung cancer than the general population. The risk largely reflects those higher rates of smoking. And so increased efforts really need to be directed at evidence-based smoking cessation. Lung cancer screening can be an effective tool to reduce lung cancer mortality in people with HIV. It's kind of being underutilized now and probably not tailored to the population. So I think tailored and streamlined approaches to both primary and secondary prevention, and hopefully combining those for patients who are eligible for lung cancer screening in the real world will both improve that effectiveness of smoking cessation lung cancer screening for your patients. All right, apologies for going over.
Thank you, Dr. Triplett. I know you have to run off to clinic, so I will let you know if there's any questions that come up. I can, if people want to put in questions, if you have another minute while Dr. Menon gets logged on here.
That sounds great. And then what's the name of the screening tool? There's a modified version that's for people not with HIV called screenlc.com. But hopefully we're going to have the tool for people with HIV up and running soon and available.
And then there's one other question in the Q&A section. For the lung cancer data, is that solely based on cigarette use, or does it include any marijuana use for those who live in recreational medical marijuana sales states?
Yeah, the data on marijuana has been difficult to ascertain because it's actually really hard to quantify. So if you just look at it in terms of raw exposure versus not, there's so much overlap with other inhaled exposures that it's been difficult to kind of parse out in terms of marijuana's association with any lung diseases, including lung cancer. So I think that's tough to say. And people ask about that for screening, and we have no way to kind of quantify it and you know, use that data to see if people are eligible or not. All right, thanks everybody.
Thank you.
Great. Thank you all for attending. Thanks, Maddie. This talk is more of a broad-based look at the changing epidemiology of HIV-associated malignancies with implications for prevention, screening, and treatment. This is the same disclaimer as Dr. Triplett showed, and I don't have any conflicts of interest to disclose. And for data considerations, data in this presentation offer a limited perspective of how systemic, social, and economic factors impact health. We recognize that racism, not race, creates and perpetuates health disparities. So the objectives of this talk are to describe some epidemiological trends of HIV and HIV-associated malignancies, definitions regarding AIDS defining and non-AIDS defining malignancies, and the impact of antiretroviral therapies on cancer-related outcomes. So you all are more familiar with this data than I am. This is from the World Health Organization, and there's approximately 37 million people living with HIV globally. Of this, 25 or 26 million reside in sub-Saharan Africa. Fortunately, the number of new HIV infections globally has been decreasing, in large part given the prevention efforts that you all are working on. And given, as Dr. Triplett mentioned, given the increasing lifespan, in part because of antiretroviral therapy, the total number of people living with HIV globally has continued to increase. Now, the relationship between HIV and cancer was really known from the origin. This was the initial MMWR from 1981, so over 40 years ago, where colleagues in New York and San Francisco with the Centers for Disease Control noted a cluster of Kaposi sarcoma and pneumocystis pneumonia among gay men again, in New York City and California. And they noticed an increase in these entities, and they were clustered among 2 cities. And that really set an alarm off in the minds of these public health officials. And they compared the data over the past 10 years, and they noted that there were no documented cases, for example, of Kaposi sarcoma, a rare vascular tumor, in the New York University Coordinated Cancer Registry. And so this was in 1981, prior to identification of HIV, and definitely prior to the identification of the virus specifically responsible for Kaposi sarcoma. But they were very prescient in this MMWR, and noted that there must be an activation of an oncogenic virus during periods of immunosuppression, which may result in the development of Kaposi sarcoma. And as we know now, that in fact is very true. The relationship between HIV and cancer is also more recent, and this is one of reports among a few now of really a cure for HIV among patients using therapies that we use for cancer. This initial report described a patient with acute myeloid leukemia and HIV infection who received a stem cell transplant in Berlin. The oncologist and the bone marrow transplant physician recognized previous data which indicated that people with mutations in the CCR5 co-receptor gene were protected from HIV. And so they searched the registry to find a matched unrelated stem cell donor who was also homozygous for the CCR5 delta 32 mutation. And fortunately, that transplant was successful, not only curing the patient of leukemia, but also from HIV. And this represented the first patient ever cured of HIV infection. There have been other patients now, just a handful, who appear to be cured of HIV with bone marrow transplants, including a woman who received a cord blood transplant. Now, obviously, the toxicities of these therapies, the cost of these therapies, the logistics of these therapies don't make this a practical option, but more of a proof of principle that cure can be achieved. When we talk about HIV and cancer, we have 2 big buckets: the AIDS-defining cancer and the non-AIDS-defining cancers. The AIDS-defining cancer, in part due to history, a historical definition included Kaposi sarcoma, non-Hodgkin lymphoma, and cervical cancer, and so named because the identification of one of these malignancies with the diagnosis of HIV made the criteria for AIDS. These were also associated with another cancer-causing virus, human herpes virus 8 for Kaposi sarcoma, EBV for non-Hodgkin lymphoma, and the human papillomavirus for cervical cancer. For non-AIDS defining cancers, they include anal cancer, liver cancer, Hodgkin lymphoma, and, as Dr. Triplett mentioned, lung cancer. And of these, anal cancer, liver cancer, and Hodgkin lymphoma are also associated with another cancer-causing virus, the human papillomavirus, hepatitis virus, and Epstein-Barr viruses respectively, but lung cancer is the one that is not associated with another virus as far as we know. Notably, the AIDS-defining cancers are more common soon after an HIV diagnosis, whereas the non-AIDS defining cancers are more common greater than 5 years after the initial diagnosis of HIV. And Dr. Triplett mentioned some of this, but what is the risk compared to someone without HIV? So for Kaposi sarcoma, it's 500-fold increased. Again, the etiologic agent is HHV8. For non-Hodgkin lymphomas broadly, it's 12-fold, but for a specific type of non-Hodgkin lymphoma, CNS, primary CNS lymphoma, it's a greater than 150-fold increase. And so for cervical cancer, it's a 3-fold increase. Anal cancer, it's a 20-fold increase. Liver cancer, a 3-fold increase. Hodgkin lymphoma, an 8-fold increase. And as Dr. Triplett mentioned, roughly a 2-fold increase for lung cancer. This is a illustration from an article in The Lancet looking at incidence over time. And you can see that the AIDS-defining cancers have really decreased starting in the late 1990s, which corresponds with the more widespread availability of our antiretrovirals. The non-AIDS defining cancers, though, have remained relatively stable in incidence during this time. This is some data from the National Cancer Institute. It's a little old, but the theme is still accurate now, that the standard incidence ratios of for these malignancies is quite elevated. So for the AIDS defining malignancies, if we look at the middle column, non-Hodgkin lymphoma is responsible for roughly 20% of all cancers among patients living with HIV. The next highest is Kaposi sarcoma at 12%, then lung cancer at 11%, and anal cancer at 10%. But these 9 cancers represent nearly 70% of all the cancers we see among patients with HIV. And so why are patients with HIV at such increased risk? And why is there an increased incidence of cancer? It's still, parts of this are still unanswered, but we think there's a lot of different potential reasons. One is immune dysregulation, with HIV leading to an impaired immunologic control of oncogenic viruses such as HHV8. Immune exhaustion is a hypothesis, and this, we think about certain therapies such as immunotherapy in a way to try to unexhaust these exhausted T cells. Another factor is chronic antigen stimulation, which can dysregulate the mucosa, leading to changes, epithelial changes, cytokine dysregulation, proliferative signaling such as angiogenesis, long-term ART toxicity, although that I think is quite controversial, and as Dr. Triplett mentioned, increase in smoking prevalence, which leads to an increased risk of a host of malignancies, not just lung cancer. So this is data also looking at the causes of death among patients with HIV. The dark blue line, which is on the top, are AIDS related, and that does include the HIV associated, the AIDS related, the AIDS associated malignancies or AIDS defining malignancies. And we can see that curve is has a downward trajectory. The light blue, again, has been relatively stable, the third line or the fourth line down. Again, AIDS-related death has decreased over time, but the non-AIDS defining cancers remain relatively stable. Apologize for that, that arrow. And this is data from a colleague who used to work at the Fred Hutch, then at the NCI, and now is at Moffitt Cancer Center, where she looked at cancer-specific mortality and HIV-specific mortality among patients who were HIV infected or uninfected. And on the x-axis, you see the plus and the minus, and that's whether the patient was HIV positive or negative. And you can see the cancer-specific mortality, the blue portion of the graph, is really higher for the patients who are HIV positive, with an increased age-standardized mortality compared to their uninfected counterparts, really across the board for all of these different types of cancers. And so what are the reasons for this increased mortality? Well, there's a number, including disparities in care. This is data from Dr. Saneja, who is actually going to give grand rounds in a couple of weeks for radiation oncology. A number of factors include a delayed diagnosis, patients present unfortunately with an advanced stage of disease, immunosuppression and age-related complications, and lack of appropriate treatment. And this is independent of insurance status and comorbidities. This is what Dr. Triplett was mentioning, some of the provider concerns which are not borne out. And what are those provider concerns? Well, some of the providers feel, well, patients with HIV have been not included in those clinical trials, so are the data relevant to patients with HIV? There have been historically a lack of cancer treatment guidelines. Currently, the National Comprehensive Cancer Network, or the NCCN, which does provide guidelines for cancer care in a very algorithmic fashion, does include a section on the care of patients living with HIV. And there have been previous concerns about the combination of giving someone chemotherapy and antiretroviral therapy. Would it be too toxic? And now we know that it's not too toxic. And in fact, patients, generally, the outcomes are better when we can co-administer these agents. So with regard to prevention, this was a study from 8 years ago, the START study, and it was the initiation of antiretroviral therapy in early asymptomatic HIV infection. And these were patients who were HIV infected, but antiretroviral therapy naive with a CD4 count greater than 500. And they randomized patients to an early antiretroviral group who received antiretroviral therapy immediately following randomization, or they deferred antiretroviral therapy until the CD4 count declined to less than 350 or had met the definition of AIDS. And at the time of this study, there was equipoise regarding this question. And the study demonstrated that patients who had initiated antiretroviral therapy immediately were much less likely to develop Kaposi sarcoma in particular, with a trend toward lower risk of malignant lymphoma as well. And lymphoma here was sort of put all together. I suspect if they looked at some of the aggressive lymphomas, the diffuse large B-cell lymphomas, Burkitt lymphoma, they likely would have been able to see a difference, a statistical difference here as well. So as a result of these findings and those of other similar studies, and you all know this better than me, early initiation of antiretroviral therapy is now the standard of care. Again, this just shows that the time to first primary event, whether it was infection or malignancy, the folks who received immediate initiation had a delayed onset to time to first event. And so in summary, people with HIV infection are at increased risk for a number of different cancers compared to HIV uninfected individuals. Disparities persist with regard to cancer diagnosis and treatment outcomes among people with HIV. Most patients with HIV who develop cancer should be offered the same cancer therapies as HIV negative individuals, including clinical trial participation. We are trying to work on this at the Hutch. To date, still, most clinical trials exclude patients nationally with HIV, and we're trying to include language to, if the patient's HIV is well controlled, if they have been on antiretroviral therapy, if they meet a certain threshold for CD4 count, depending on the investigational agent, then they should be included in that clinical trial. Patients with HIV and cancer should be co-managed with an oncologist and an HIV specialist. I feel thankful to work in the Madison Clinic, where I get to work with HIV specialist, HIV pharmacist, and social workers and the whole team. And that is it, just as the same acknowledgement as shown before. I am happy to answer any questions. Thank you. Just this last slide. So our group at the Hutch we have a research program in Uganda with the Uganda Cancer Institute. This, just as some background, this Cancer Institute was started by infectious disease colleagues, our collaboration was started by infectious disease colleagues, Christine Johnson, Corey Casper, Larry Corey, Julie McElrath, given an interest in studying Kaposi sarcoma initially, and given the declining incidence of KS here, colleagues wanted to study it where it was more present, and it unfortunately is quite prevalent in Uganda. This established our relationship with the Uganda Cancer Institute, which has continued today, where we have a large research platform in a variety of malignancies, including Kaposi sarcoma. Whoops. Thank you.
Thank you so much, Dr. Menon. Dr. Schouten has a question about addressing screening for cancers other than lung cancer.
Great. Well, he is the expert in this, and there was a study that Dr. Schouten and others published or led, and including our patients at Harborview, that demonstrated the benefit of, it was an anchor study published in the New England Journal last year, which demonstrated the benefit of screening for anal cancer. And Dr. Schouten and I share a number of patients that during that study and after that study, I've been able to see who were detected with really local or locally advanced anal cancer, as opposed to more distant disease. So that has really been practice changing in terms of lung or anal cancer screening. You know, we do cervical cancer screening, and the guidelines in terms of frequency of cervical cancer screening varies based on HIV status, the frequency, and the potential use of co-testing. So that's important. Lung cancer, as Dr. Triplett just mentioned, we don't have real screening per se for other cancers, in part because we don't have great screening for patients living with HIV, given that we don't have that much screening for that has been shown to be effective for our other cancers. But the patients living with HIV should still adhere to the same guidelines for screening as we do for patients not living with HIV with regard to colon cancer and breast cancer.
If there are any other questions, you can put them in the chat or in the Q&A. Thank you so much for leading this work, Dr. Menon. In our clinic, we're really fortunate to have you as a resource.
I'm thankful to be there.
If there are no other questions, we'll let you go on to your day. Thank you again so much for that excellent overview and talk.
Great, thank you. It was hard. I knew it was going to be a short talk, so I didn't know how much to include. It
was perfect.
Minute talk, so very good. Thank you all.
Thank you.